Today we'll do MCQ discussion for anesthesia. Okay, the first question is, what is the application of this instrument? So this type of question, this pattern of question has increased very recently, in fact after 2018 or from 2018. So this instrument is ambu bag, and the application of ambu bag is ventilation. And ambu bag is ambu. The word ambu is an abbreviation for ambulatory breathing unit. AMM, ambulatory breathing unit. Ambu bag. So it is a self-refilling bag. It's a self-refilling bag valve bag with valve mask unit. Bag valve mask. You see, here we have mask. Here we have bag. Here we have valve. With the capacity of 1 to 1.5 liter capacity, used for ventilation and oxygenation for intubated patients, allowing both spontaneous and artificial respiration. Spontaneous and artificial respiration. Okay, so this is the application of this instrument. Very important. Okay, next question. Laryngeal mask airway is used for maintenance of the airway, facilitating laryngeal surgery, prevention of aspiration, removing oral secretion. And the answer will be maintenance of the airway. It is placed blindly in oropharynx. Laryngeal mask airway is placed blindly in oropharynx, and the cuff is inflated with a large volume of air. And the cuff is inflated with large volume of air, like 30 to 40 ml for adult size. Now, inflated cuff seals the lateral and posterior pharyngeal walls, and the patient can be ventilated through ventilation ports. So, this is laryngeal mask airway. And when it is used, laryngeal mask airways, it is used as an alternative to intubation where difficult intubation is anticipated. So it is laryngeal mask airway is first of all used in place of, instead of intubation, where it is difficult to use. Next, securing airway in emergency. Securing airway in emergency where intubation and mask ventilation is not possible. Securing airway in emergency where intubation and mask ventilation is not possible. So simply securing airway in emergency. Number 3, as an elective method for minor surgeries where anesthetist wants to avoid intubation. So minor surgeries where anesthetist wants to avoid okay, so avoid intubation. Number 4, as an conduit for bronchoscopes, small size tubes, gum elastic bogies. So conduit for conduit or channels. Okay, conduit or channels for bronchoscope. Small tubes and elastic bogies, gum elastic bogies. Conduit means channels for bronchoscopes. So what are the advantages? It is easy to insert. Even paramedical staffs can also insert. Does not require any laryngoscope. Does not require any laryngoscope and muscle relaxant. Does not require any specific position of cervical spine, so it can be used in cervical injuries. And the disadvantages are it does not prevent aspiration. So should be used for should not be used for full stomach, because if it is used, there is a chance that the food from the stomach can regurgitate and there will be choking. There can be choking and death also. So high incidence of laryngospasm can occur and bronchospasm when, especially during the insertion, there can be laryngospasm and bronchospasm. Okay, so when it should not be done? Contraindications: full stomach patient, number 1. Because cannot prevent aspiration. Because cannot prevent Next is hiatus hernia. Hiatus hernia, pregnancy, where chances of aspirations are high. Oropharyngeal abscess or mass. Oropharyngeal abscess or mass. Patients who are vulnerable to go in bronchospasm. Patients who are vulnerable to go into who may have bronchospasm. An oropharyngeal abscess or oropharyngeal mass. Hiatus hernia in pregnancy. Because in this situation, although full stomach is not there, but there may be high chance of aspiration. That is why. So very important question, laryngeal mass airway, a very important topic from anesthesia. If something comes from anesthesia, 2 or 3 questions, there may be 1, 2, 3 questions from anesthesia. If or more, there can be more also. Questions from laryngeal mass airway and ambubag and some other more questions we will do. This type of questions have the highest probability to come. You can get questions from frequently from these topics from anesthesia in FMG. So next question: a patient is on mechanical ventilation in intensive care unit. Now ventilator is showing alarms for increase in both peak and plateau pressure during inspiration. So this indicates obstruction of tracheal tube, decrease in distensibility of lungs and chest wall, acute bronchospasm, and increased compliance of lungs. And the answer will be obstruction of tracheal tube. So patient is on mechanical ventilation. Now, see situation or scenario you see scene. Patient is in mechanical ventilation. In ICU. Ventilator is showing alarms for increase in, so that means signs of increase in both peak and plateau pressure during inspiration. Signs of increase or chances of increase in peak and plateau pressure during inspiration, during inspiration. So what does this indicate? It indicates obstruction of tracheal tube. It indicates obstruction of tracheal tube. Now, why this pressure is increasing? Because you see, tracheal tube is obstructed and the air cannot come out during expiration, and so during inspiration the air cannot go in also, and that is why the pressure is getting increased a lot, much more than normal during inspiration. So esophageal intubation, you see, this is a hazardous complications, if not detected in time, can cause severe hypoxia and even death. Ischemia, edema, and necrosis at local site, aspiration, bronchial intubation, and collapse of other lung. Tracheal tube obstruction by secretion or kinking. So now tracheal tube obstruction. Now tracheal tube obstruction happened, air cannot come out, and during inspiration air also cannot go out, and if a little bit of air goes in, I mean during inspiration air cannot also cannot come in into the lungs, and if a little bit of air comes in into the lungs during inspiration, the pressure is increasing a lot. Pressure is increasing a lot. Now tracheal tube obstruction occurred. This shows tracheal tube obstruction occurred. Now why it occurred? Maybe due to secretion. Accidental extubation. Trauma to gums, lips, epiglottis, pharynx, larynx, nasal cavity. Reflex disturbances like laryngospasm, bronchospasm, breath holding, cardiac arrhythmia, hypertension, or even cardiac arrest. Okay, so cardiac arrhythmia, hypertension, and even cardiac arrest. So these are the complication of intubation. Perioperatively, that means after the operation or before the operation, okay, or during the operation as well. Perioperatively. Okay, next question. Oxygen cylinder color should be black body, white shoulder. White body, black shoulder. Brown body and shoulder, both body and shoulder is brown, and both body and shoulder is blue. Very important question. In fact, in the recent past, question came from this table. I will show you. The answer is black body, white shoulder. This table must be grasped completely. Now oxygen, if in the cylinder there is oxygen, then the color code is body will be black while shoulder will be white. And pin index, very important, 2,5 pin index position. For nitrous oxide, blue with blue, 3,5. For only air, whole air, gray, body gray, white or black quartered 1,5. CO2, if CO2 is there, then gray 1,6. Helium brown again 2,5. So for 2,5 there can be oxygen, there can be helium also, but for oxygen body and shoulder, body should be black body, and white shoulder. Okay, and the whole table must be learned by heart. Okay, for FMG, very important, for FMG to remember this, very important. Okay, next, pin index safety mechanism in anesthesia machines are basically used to prevent wrong attachment of the cylinder, prevent incorrect attachment of the anesthesia machines, prevent wrong inhalation drug delivery, prevent incorrect anesthesia mask, face mask attachment. And the answer will be wrong attachment of the cylinder. So pin index are used to prevent wrong attachment of the cylinder. This to prevent wrong attachment of the cylinders. Prevent wrong attachment to the cylinder. The cylinders. Okay. Okay. Next. So each gas cylinder has 2 holes in its cylinder. Each gas cylinder has 2 holes in its cylinder valve that combine or get attached with corresponding pins in the yoke of the anesthesia machine. So each cylinder has a particular pin code. Unless the correct cylinder valve is attached, the pin holes will not coincide. So it is practically impossible to fit any cylinder to the wrong yoke. To discourage incorrect cylinder attachment, pin index safety system has been adopted. And to prevent misconnection, gas cylinder valve blocks have holes drilled in 2 of 6. That's a single hole in entonox. There will be single hole. Otherwise, have hole drilled in 2 of 6. That's why there is 2 numbers, 1, 5, 1, 6, like this. The pin index safety system is also ineffective if yoke pins are damaged or cylinder is filled with wrong gas or using extra sealing washers. Okay. Okay. ETT is not useful for endotracheal tube, is not useful for pneumothorax, pulmonary toilet, obstruction, decreased level of consciousness. And the answer is pneumothorax. So ETT is endotracheal tube toilet, or simply we call it sometimes endotracheal tube. It involves clearance of airway secretion. So clearance of airway secretions and is a normal process needed for preservation of airway patency and prevention of respiratory tract infection. So it is not useful for pneumothorax. Main application is ETT is mainly used for to keep the airway patent. To keep the airway patent, maybe by clearing the secretion, and also by preventing respiratory tract infection, RTI. Respiratory tract infection. Impaired clearance of airway secretion, like in patients with depressed level of consciousness. can result in atelectasis and pneumonia as well, and may contribute to respiratory failure. So impaired clearance of airway secretion, if the airway secretion is not cleared completely, what can happen? Can result in atelectasis and pneumonia, especially in depressed level of people with people with less consciousness, depressed level of consciousness, and it may contribute to respiratory failure. It may contribute to respiratory failure. So the primary indication for tracheal suctioning is to remove secretion. Remove secretion in order to enhance oxygenation or to obtain samples of lower respiratory tract secretions for diagnostic test. In the end, perform tracheal suctioning after endotracheal intubation to clear the airway of aspirated material and secretion, or to enhance the oxygenation in a tracheostomy patient with respiratory insufficiency. Next, perform bronchopulmonary toilet when secretion are visible in the endotracheal tube or at the orifice of the tracheostomy tube. Perform tracheal suctioning when the patient has the coarse rales, rhonchi, or tubular breath sounds, acute or worsening dyspnea, or arterial oxygen desaturation. Okay, next question. American Society of Anesthesiologists scores assess oral cavity for intubation, overall health status of patient, risk factors, or pain scale. So American Society of Anesthesiologists score assess. Let's see. Class 1, healthy patients with no organic, scores assess overall health status of the patient. Overall health status of the patients. So let's see the different classes. Class 1, healthy patients with no organic or psychological disease process. Class 2, a patient with mild to moderate systemic diseases. So mild to moderate systemic disease caused by the condition to be treated surgically or other pathological process which does not limit the patient's activity in any way. Number 3, patients with severe systemic disease is class 3. From any cause which imposes a definite functional limitation on activity. Number 4, a patient with severe systemic disease which is a constant threat to life. Constantly life-threatening condition. A moribund patient, number 5, moribund patient, unlikely to survive with or without surgery. So a moribund patient. So this is class 1, this is class 2, this is class 3, this is class 4, and this is class 5. 5 classes of ASA physical status scale. American Society of Anesthesiologists physical status scale scores overall health status of patients. Overall health status of patients. Okay, next question. Local anesthesia acts by blocking calcium channel, sodium channel, both sodium and calcium channel, none of this. So local anesthesia acts by blocking sodium channel. Now LA, local anesthesia acts by blocking the sodium channel, very important mechanism. With this blockade, there is a decrease in entry of obviously sodium ions. That means entry of sodium ions into the cells during action potential. So as the local anesthesia concentration is increased, the rate of rise of action potential and maximum depolarization decreases, causing slowing of conduction. Slowing of conduction in that portion. And there will be a time when local depolarization fails to reach the threshold potential and conduction is completely blocked. Exposure to higher concentration of calcium. Now higher concentration of calcium reduces the inactivation, higher concentration of calcium reduces the inactivation of sodium channels. So first, local anesthesia was decreasing the sodium ion entry. And next, it reduces the sodium channels inactivation. That implies what? That implies it lessens the degree of block. Okay. So higher concentration of calcium, this causes when higher concentration of calcium occurs. So these two mechanism process you need to understand. Lignocaine is the most commonly used local anesthetic. Lignocaine is the most commonly used local anesthetic agent. It is the DOC for the treatment of ventricular arrhythmias. Ventricular arrhythmias, very, very important. DOC of ventricular arrhythmias. Even this is a question. Is lignocaine. But due to digital toxicity is ineffective in atrial arrhythmia. Not in atrial arrhythmia, but in ventricular arrhythmia only. Okay, next question. In local anesthesia, fibers first affected are A, B, C, D. Which fiber? The answer will be C. C fibers are first affected. And the senses that are blocked in a order. First, the pain sensation will be blocked. Then temperature sensation will be blocked. Then the touch sensation will be blocked. Then pressure means deep touch actually will be blocked. And after that, in fact, taste also get lost. Taste, especially the bitter taste, get lost. In local anesthesia, nerve fibers first block is type C, which is followed by B, lastly A. So C, B, A. Smaller diameter fibers and non-myelinated fibers are blocked more easily at low concentration, followed by thicker myelinated fibers. Obviously, smaller plus non-myelinated are blocked more easily than thicker myelinated. Minimum concentration of local anesthesia required to block a nerve fiber is called CM. Minimum concentration is denoted by CM. Concentration minimum. Okay, so this, remember these sequences in where this is sensory loss sequence. This is type of fibers, types of nerve fibers or nerve fibers loss. This is, and this is the the structure according to structure of neurons, or yeah, neurons can be said as neurons. Okay. Okay, which of the following doesn't belong to the Easter group of local anesthetics? Which of the following doesn't belong to the Easter group of local anesthetic agents? Chlorprocaine, tetracaine, benzocaine, and dibucaine. And the answer will be dibucaine. Because dibucaine is an amide group. It's an amide group. Ester, there are two types of anesthetic agents, ester group and amides group. Ester group, cocaine, benzocaine, chlorprocaine, tetracaine, while amides, lignobupivacaine, prilocaine, dibucaine, and etidocaine. You see, all these amide groups contains 2I, D, 1I, caine, I, and all 1I containing are ester. So this is a remembering fact, good fact. Okay, next question. Which of the following statement is true about ether as an anesthetic agent? Used with muscle relaxant, slow induction, high risk of cardiac arrhythmia, recovery faster. So which of the following statement is true about ether as an anesthetic agent only? And the answer will be slow induction. Blood gas coefficient of ether is 12, which means ether has slow induction, slow recovery. Slow induction, slow recovery. Always remember, ether induces anesthesia slowly, slow induction plus recovers also slowly. Irritant vapor which readily induce laryngeal spasm make induction even slower and stimulate salivary and bronchial secretions, so atropine as pre-medication is required. Because it will, atropine will decrease salivary, being anticholinergic will decrease salivary and bronchial secretion. And so before using going for an irritant vapor as anesthetic agent, we should use atropine. Next point. Ether is highly inflammable, causing explosion with cautery. Should not be used when diathermy is needed in the airways because risk of fire or explosions is there. Risk of fire and explosions is there, and muscle relaxant need not to be used as ether induces ether itself produces excellent relaxation. So no muscle relaxation. So remember, ether with ether you don't have to, no need to use muscle relaxant. Liberates catecholamine and tends to maintain blood pressure. Cardiac arrhythmias occur rarely with ether, and there is no sensitization of myocardium to circulating catecholamines. Adrenaline is relatively safer with ether. Bronchial smooth muscle is relaxed. Okay. So next question. Most cardiotoxic local anesthetic agent is most cardiotoxic bupivacaine. It's a local anesthetic agent from amide group. From amide group. 2I. Most cardiotoxic is local anesthetic. It is the most cardiotoxic local anesthetic, bupivacaine. Shortest acting local anesthetic is chlorprocaine. Longest acting local anesthetic is dibucaine. Most commonly used local anesthetic is lignocaine. Most local anesthetic which causes methemoglobinemia is prilocaine. So remember these facts, very important. It may come in the FMG also, and obviously, so very important. Okay, so all these extremes must be remembered. Extremes must be remembered. Shortest acting LA, chlorprocaine. Longest acting LA, dibocaine. Most commonly used LA, ligno. Local anesthetic which causes methemoglobinemia is prilocaine, and most cardiotoxic LA is bupivacaine. Okay, so these are all important facts. Okay, next question. Which of the following drugs causes malignant hypothermia? Mivacurium, pancurium, succinylcholine, atracurium. And the answer is succinylcholine. Now, malignant hypothermia, what is it? It's a condition usually triggered by exposure to certain drugs used for general anesthesia, especially the volatile anesthetic agents and neuromuscular blocking agents and succinylcholine. So succinylcholine. So succinylcholine is a depolarizing, non-competitive, non-competitive MR with shortest duration due to rapid hydrolysis by pseudocholinesterase. MR means muscle relaxant. Now, succinylcholine causes dual or biphasic block. Very important. This terminology is also very important. It can come like this. The mechanism of succinylcholine is dual or biphasic block. It causes hyperkalemia, increased intraocular, intragastric pressure, temperature also, leading to malignant hypothermia. Susceptibility to malignant hypothermia often inherited as an autosomal dominant disorder. It can be autosomal dominant disorder also, for which there are at least 6 genetic loci of interest, most prominently ryanodine receptor gene, RYR1, ryanodine receptor gene. DOC of malignant hypothermia is dantrolene. So DOC of malignant hypothermia is dantrolene, very important. It works by succinylcholine works by dual or biphasic block, causes hyperkalemia, increased intraocular and intragastric pressure and temperature, leading to malignant hypothermia. It can be genetic origin also, autosomal dominant disorder in that case. Okay, so that's it about succinylcholine. So next question, all are true about succinylcholine except short acting muscle relaxant, neostigmine antagonizes this action, responsible for post operation muscle pain, and all are true. So the answer will be neostigmine. Neostigmine antagonizes this action. So it is false. So shortest acting muscle relaxant, succinylcholine is the shortest acting muscle relaxant. Yes, responsible for post-operation muscle pain. Also yes, but this is wrong information. Neostigmine antagonistic action. Depolarizing or non-competitive muscle relaxant are not antagonized. Non-depolarizing competitive muscle relaxant like succinylcholine and are antagonized by acetyl. Okay, depolarizing non-competitive muscle relaxant like succinylcholine are not antagonized, but the opposite of succinylcholine, those muscle relaxant like non-depolarizing competitive muscle relaxant, they are antagonized by acetylcholine or acetylcholinesterase and antagonized by neostigmine, pyridostigmine, and edrophonium. In order to prevent muscarinic effects, atropine is given in combinations. Which is the shortest acting non-depolarizing muscle relaxant? Non-depolarizing muscle relaxant. Becuronium, mivacurium, succinylcholine, heterocurium. So the answer will be mivacurium. Succinylcholine, as we studied just now, depolarizing, not non-depolarizing. Non-depolarizing muscle relaxant are including galamine, D-tubacurarine, atracurium, mivacurium, vicuronium, pancuronium, rocuronium. So the shortest acting non-depolarizing muscle relaxant is mivacurium. Shortest acting depolarizing muscle relaxant is succinylcholine. Overall shortest acting muscle relaxant is succinylcholine. Shortest acting local anesthetic is chlorprocaine. Shortest acting local anesthetic is chlorprocaine. Which of the following? Next question. Which of the following is not an effect of suxamethonium? Hyperkalemia, increase intragastric pressure, histamine release, myalgia. The answer will be histamine release. Now the suxamethonium produces muscarinic effect similar to acetylcholine. It can cause profound bradycardia. So atropine should be given prior to use of succinylcholine, especially in children. Hyperkalemia is caused due to excessive muscle fasciculation. Ventricular arrhythmias can occur due to hyperkalemia. In normal subjects, serum potassium by 0.5 milliequivalent per liter increases. Succinylcholine increases intracranial tension due to contraction of neck muscles, blocking venous outflow from cranium. This rising can be prevented by pre-curarization. Pre-curarization. That means before giving succinylcholine, we will go for tubocurarine. We will go for D-tubocurarine. Then we will go for succinylcholine. So it will decrease the effect of succinylcholine. Ocular muscles which are multiple undergo tonic contraction after administration of succinylcholine, increasing the intraocular tension. So ocular muscles which are multiple undergo tonic contraction after administration of succinylcholine increase the IOT. This increases in IOT cannot be avoided by pre-curarization. This is a technique in which 1/10 dose of non-depolarizing muscle relaxant MR is given 3 minutes to succinylcholine prior to giving succinylcholine. 3 minutes prior to giving succinylcholine. So we need to give non-depolarizing muscle relaxant, especially tubocurarine. We can use other MR also like mevacurium, vacurium will have the same effect. This is called pre-curarization. Intragastric pressure is increased due to the contraction of abdominal muscles, and this increases intragastric pressure, which can cause aspiration in vulnerable individuals. Normal intragastric pressure more than 28 centimeter H2 of H2O is required to overcome the competency of the gastroesophageal junction, and in condition like pregnancy, hiatus hernia, ascites, pressure of more than 15 centimeter H2O can cause aspiration. So pre-curarization is necessary in these conditions. Okay, so the question was which of the following is not an effect of succinylcholine, and the answer is histamine release. Hyperkalemia is the effect of succinylcholine. Increased intragastric pressure is the effect of succinylcholine, and myalgia is the effect of succinylcholine. Succinylcholine is just similar to succinylcholine, and that's why we studied about succinylcholine here. Okay, next question. Anesthesia of choice in pediatric patients is ketamine, desflurane, sevoflurane, propofol. And the answer is sevoflurane. So we will go one by one each of these anesthetic agents. First of all, sevoflurane. Sevoflurane is one of the inhalational anesthetic agents. Induction and emergency emergency anesthesia is rapid. Emergence of anesthesia is rapid with sevoflurane. So rapid induction, summarizing it, rapid induction, inhalational induction, absence of pungent smell makes it pleasant and administrable through face mask, considered as anesthesia of choice in pediatric patients. They will cooperate. Side effects, respiratory depression, arrhythmia, very important. Side effects always important. Pediatric patients and side effect, respiratory depression, and arrhythmia. Desflurane is one of the inhalational agents. Again, fastest acting but less soluble than isoflurane. Fastest acting. Most pungent odor make it unsuitable for induction. Irritates air passage, may induce coughing and laryngeal spasm, laryngospasm, whatever. So induce coughing and laryngeal spasm. Next is propofol. Anesthesia choice for day care surgery. Very important, day care surgery. Short acting, action diminishes the same day. Very much short acting. Advantage has antiemetic property. Antiemetic property. Safe in porphyria. Safe in porphyria. Disadvantages causes myocardial depression and hypotension. Myocardial depression, hypotension. So next, ketamine. Ketamine has maximum analgesic property. Produces dissociative anesthesia. Dissociative anesthesia. Induction agent of choice in asthma patient. Induction agent of choice. All of the following drug will cause malignant hyperthermia except nitrous oxide, desflurane, isoflurane, sevoflurane. So the answer will be drug will cause MH except which will not cause nitrous oxide. So malignant hyperthermia is a life-threatening clinical syndrome of hypermetabolism involving skeletal muscle. Hypermetabolism involving skeletal muscles. Triggered in susceptible individuals primarily by the volatile inhalational anesthetic agents and muscle relaxant succinylcholine. The most common triggering agents are volatile anesthetic agents such as halothane, sevoflurane, desflurane, isoflurane, influrane, and or the depolarizing muscle relaxant MR, succinylmethonium and dexamethonium. Anesthetic agents that are considered safe include local anesthetics like lidocaine, bupivacaine, mepivacaine, opiates, ketamine, barbiturates, nitrous oxide, propofol, etomidate, and BGT or benzodiazepines. These are considered safe during including local anesthetics. Non-depolarizing MR which are safe are pancuranium, cisatracurium, atracurium, mivacurium, vecuronium, rocuronium. Also do not cause MH. Also do not cause MH. Drug producing dissociative anesthesia. Drug producing dissociative anesthesia include propofol, enflurane, ketamine, sevoflurane. Producing dissociative anesthesia, ketamine. So it possesses analgesic properties and it produces cardiovascular stimulations. It causes dissociative anesthesia, characterized by profound analgesia, immobility, amnesia, feeling of dissociation from one's body and the surrounding. That is dissociative anesthesia. Like the body is becoming lighter, the patient may tell like that. And profound analgesia occur, immobility, patient cannot move, deep anesthesia occur, profound anesthesia occur, anesthetic effect occurs. In addition, it also causes hallucinations, delusion and illusions, and profound analgesia. Ketamine increases all pressures. Remember, ketamine increases all kind of body pressures, including BP, ICT, intracranial tension, intraocular pressure. So contraindicated in intracerebral mass or hemorrhage. Must not be given. Which anesthetic agent is contraindicated in porphyria, propofol, ketamine, thiopentone, and etomidate? The answer will be thiopentone. Anesthetic agent is contraindicated in porphyria. It is an ultra short acting. Thiopentone is ultra short acting thiobarbiturates because of rapid redistribution. It has poor analgesic property. IV injection is very painful. Therefore, it is contraindicated unless opioids or sodium, nitrogen, oxygen has been given. Contraindicated in porphyria patients. Very, very important. Etomidate is contraindicated in adrenal insufficiency and drugs safe in patients with porphyria is propofol. Drugs that are safe in patients with porphyria is propofol. High spinal anesthesia is characterized by hypertension, tachycardia, hypertension, bradycardia, hypotension, tachycardia, and hypotension, bradycardia. High spinal anesthesia is characterized by hypotension and bradycardia. Both hypo, basically. It causes central neuraxial blocks. Remember, high spinal anesthesia will cause central neuraxial block. That's why there will be hypotension. There will be hypotension. Now, this hypotension occurs due to venodilation, dilatation of post-arterial capillaries, decreased cardiac output, and decreased cardiac output occurs due to decreased venous return, bradycardia, which can occur as a result of decreased atrial pressure because of decreased venous return, Bainbridge reflex, direct inhibition of cardioaccelerator fibers. Paralysis of nerve supply to adrenal glands with consequently decreased catecholamine release occurs, and direct absorption of drug into systemic circulation occurs in case of high spinal anesthesia. Direct absorption of drug into systemic circulation. And compression of inferior vena cava and aorta by pregnant uterus, abdominal tumors. Inferior vena cava compression occurs and aorta also by pregnant uterus or abdominal tumors. Occurs in this type of anesthesia. And we call it supine hypertension syndrome. In nervous system, what happens? Autonomic fibers mediated by C fibers are most sensitive, and they are blocked earliest followed by sensory and then motor fibers. So sequence of block is autonomic, sensory, motor. Recovery occurs in reverse order, although number of studies have suggested return of autonomic activity before sensory. Okay. So next question, which is not a complication of giving anesthesia to chronic smoker. Less mucosal secretion, increased mucosal clearance, atelectasis, hyporeactive airway. Which is not a complication of anesthesia to a chronic smoker? And the answer is increased mucosal clearance. From anesthesiological perspective, smoking increases the relative risk of post-operative pulmonary complications up to 6 times. So a common A common is the increased. So that means there will be if for a smoker there is increased risk of laryngospasm and bronchospasm post-operative post-operatively. Okay, post-operatively. High levels of carbon monoxide limit the ability of hemoglobin to bind and transport oxygen, predisposing surgical patients to an increased risk of hypoxia. So smoking increases airway mucus production and impairs the ciliary function, resulting in poor sputum clearance naturally. This, in combination with smoke-induced impairment of immune function, increases the likelihood of developing postoperative pneumonia. The preoperative effect of smoking, on respiratory system are hyperreactive airways, especially the smaller airways. Number 2, reduced mucociliary clearance. Number 3, increased mucus secretion. Number 4, altered surfactant and permeability. Number 5, perfusion, ventilation perfusion mismatch. So these are the reversible effects of smoking. So go through this table as well. So basically, for a smoker, what happens? Airway mucus production is already increased. Ciliary function in the airway is impaired. So basically, sputum clearance mechanism is impaired. Clearance. And if on this situation anesthesia is given, then obviously the situation pulmonary complication increases. So smoker, if smoker is given anesthesia during surgery, it has to be given. So complication, pulmonary complication increases up to sixfold. So increased mucosal clearance is due to smoking and not due to anesthesia. That has to be remembered. Very important. Okay, next question. Okay, there's no more questions. So that is the last question and last topic. Although the whole subject is a little smaller, but there are many things to learn, many things to remember. Okay, so go through all this, and very few question comes, but whatever we have discussed are all important. Anesthesia. Okay, if any question comes, it comes mostly from this type of topics only. Okay, thank you for today, and we will start with another subject next week. Thank you.